your doctors do care about you. I mean, we went into this field because we care. We're not just bad. I don't know what the word would be, but we're here because we care. We want to help you. I love that question because I do have patients that sometimes come in, and I always like to start my consult and say, "What brings you in here?" And the first thing they say is, "I'm not doing IVF." I was like, "Okay, that's fine. That's how you know it's something." I'm like, "That's fine. That's not my goal." And I tell every patient when they come in, my goal is for you to get pregnant. Whatever way we need to, that's my goal.
Welcome back, guys, to my podcast. I'm here today with Dr. Joan Bardos. He's one of my good friends, and he's also a reproductive endocrinologist. So I'm doing these series to help bridge the gap between our specialty of OBGYN to other specialties, in this case, REI, to help patients when they leave us and go to you or vice versa, they have a better transfer of care. So you want to introduce yourself?
Sure. Yeah. First of all, thank you so much for coming here today. I mean, this is a great idea. I love the idea of increasing communication between all of the care that patients are getting. I find that when that increased communication occurs or exists, it is a much smoother and better process for the patient, which ultimately results in better outcomes, which is both our goals at the end of the day. So my name is Joan Bardos. I am a reproductive endocrinology and fertility doctor. So I do IVF, I do fertility and infertility. I'm also fellowship trained in genetics and recurrent pregnancy loss. So basically, I loved to go to school until my wife told me I had to stop going to school and start making a little bit of money. Yeah, and you know my wife, so you know exactly what you could actually hear her saying that.
I can tell her that. Stop it.
Right. It's enough. Stop training. Yeah. But I did do a lot of training. I did it mainly because they were all things that fascinated me, and I wanted to be a better clinician for my patients. And in the field of reproductive medicine, there's so much that's now being that involves genetics, but having a solid understanding of not only the technology that we have, but also a lot of the genetic disorders that we see on carrier screens. I've seen them. I've treated them. I've diagnosed them in patients. So it helps when I'm talking to patients. I've actually seen a lot of these common disorders that they might be a carrier for, or both their partner might be a carrier for. So kind of bringing all that together. I'm also the medical director here at CCRM and one of the founding partners, along with Dr. Calvin Potts, who's my business partner here. A little bit about CCRM. So why CCRM? Why did we want to start CCRM down here? So CCRM is a national company. We have, I think we're almost up to 18 or 19 different sites across the country.
I want to cut you off there before we keep going. Just on a personal note, I've known you for a very long time. I did my training in Jackson, and I had the luxury of working with you as when you were a generalist. Yeah, I went through my training, so I've been able to have a relationship with you for a while. And I know the whole time you were there, you were looking on how can I build a practice? How can I reach patients? Because you know better than I do, as good of a doctor that you are, specifically in reproductive endocrinology, if you don't have the proper support of an endocrinology lab, of support staff and everything together, you could be the best in the world. But if you don't have that backing of a team, that you can't do anything at all.
Yeah.
So I was really excited when you told me you joined CCRM and you're bringing this down here, because they are one of the best labs in the country, which we do not have here before, and with one of the best success rates in the country. And you saw that as a mission to bring that, as like you're saying, the medical director here, to the patients down here. So I'm really happy that you started this, that I can now refer you patients that I do really happily, and that you can treat them now.
Yeah. So first of all, thank you. Yes. I still remember you as an intern. That was fun.
We don't need to share those stories.
Well, there's some great stories we could share. But no, my time at Jackson was great. And honestly, I did it because I loved it. I do love this field. I love the field of reproductive medicine. I also love OBGYN, which is why I was doing generalist calls while I was in my genetics fellowship, because I enjoyed it.
That's true. Now you're good at it.
And I like to teach, so it was a perfect opportunity. And he was not a bad intern, actually.
There you go.
You weren't so bad.
So
you'll edit that out.
I'll send you the money after, don't worry.
But yes, really, that you hit it on the head, right? So why CCRM really has to do with the quality and the outcomes. At the end of the day, if I'm going to open a practice, if I'm going to practice and be a physician, I want to know that I'm giving my patients the absolute best chance at success. And CCRM has maybe 15, 18, 19, by the time whatever it is gets out, practices across the country. And all of their outcomes are within 1% to 2% of each other. And the reason why is there's such a focus on quality assurance and quality control. Even to a fault, we do fewer cycles. We run fewer cycles per week just to maintain that quality, because I want to have fewer unsuccessful patients, or
You want to optimize a result.
I want to optimize, but it's not even right. So A, we get to optimize the result. B, as a doctor, patients' failures are my failures too. Like, my team feels it. It's obviously not the same as patients, but it bothers us too. So if I'm able to go through my week and have only good phone calls and only be able to call patients and tell them that they're pregnant, as opposed to saying, really sorry you weren't successful, that makes my day so much better. It makes our team so much better, and obviously it's the best for patients. So being able to work within that environment, an environment where the vast majority of what I do is happy stuff, I love. And that's great. The other thing that Dr. Potts and I really worked on here was building a team that we consider a family. You know this better than anyone else, working in your office with your mom as the
Office manager,
your dad, the one of the owners, but it creates a different environment and a different experience for the patients. So when we were choosing our staff, we knew exactly the type of office we wanted to run. We knew exactly the type of office we wanted this to be. We wanted this to be something that really focused on patient experience, patient care, and patient outcomes. So that included everything from the way we built the office, the colors we used, how we talk to patients, how our staff is set up, to kind of create more of almost a boutique experience for patients. And anyone who's seen pictures, or I don't know if you'll have some video of the actual office here, but you'll see it's set up. It doesn't look like a doctor's office. It's really, and the idea, even just the colors that are used in the wall, was to kind of create a sense of calm when you're going through an otherwise very stressful process.
I actually, I just got a tour of this place before talking to you. I highly encourage you guys to check out their website for those pictures and videos. It's beautiful. They have everything laid out. It seems very personal, and actually, because it's a new building, the layout is very friendly to people who want privacy, which is great because of the flow of the office. You don't feel like everyone's on top of each other, which is really nice.
And, I had a lot of patients, a lot of really close friends who have gone through this process, and they've given me feedback about the frustrations that they've had, and I was able to put that into the build. This being the founder, you get to be involved with the build and what it's going to look like, what the layout's going to look like, every aspect of the process, which really allows us to bring a top-notch facility and outcome to patients.
So, we're talking about here now. I kind of brought up me in residency with you as a generalist, but what really pulled you, as you told me you had so many interests, what really pulled you into reproductive endocrinology?
Well, I'll say this. I was always fascinated by hormones. I still remember in med school, endocrinology just fascinated me. How everything worked was always really, there's a lot of intellectual aspect to it, the feedback mechanisms, why when you play with one little thing, how it can change everything downstream. I've always found that fascinating. But what really pulled me in was I love bringing life into this world and helping people. And that's actually what pulled me even into the field of OBGYN, was the concept of bringing life into the world. When I was doing my medical school training and then residency, my favorite rotations were reproductive medicine, being able to help families, couples, patients who wanted nothing more than to become parents, being able to assist them in that was the most rewarding thing that I was able to be a part of. And I knew it. And I'll tell you when I really knew about it. So I had done a conference, in college. I was very involved in student leadership, stuff like that. And I put together a conference on Jewish reproductive law, because basically I was in college. So I was like, I want to challenge the norms. People don't talk about this. This is back in early 2000s. Sorry. And it was taboo to talk about infertility, but we don't talk about it. And I did not. We're going to do that. I'm going to put on a big conference, and lots of people are going to come. We're going to tell everyone about it and make sure that educate people so that they can get the help that they need. And that conference, I wasn't planning on going into the field, but I was like, this is fascinating stuff. And I still remember a year after the conference, we got an email saying, just want you to know, I've been to your conference. I was struggling for many years. I met the doctor at the conference and then just had my kid. I'm like, that is amazing. That's incredible. Even though I really had very little to do with that, but being a part of that was so exciting. So when I was in med school, I did my sub-internship or 4th-year rotation in an REI office. And I think the day that it really hit me, we were about to go into an ultrasound, and the doctor pulled me aside and he said, listen, you're going to see 3 people. You're going to see 2 sisters and a partner. This woman, one of the sisters doesn't have a uterus. She has a genetic condition. So her sister is agreeing to carry this baby. So we made the baby through IVF. We put the embryo back into the sister. And
So the sister was carrying.
the sister was carrying her sister's embryo.
She had like a mullary agenesis or something.
Exactly.
Okay.
Yeah.
Look, I remember Mars KH.
Yeah. Pluripotent agenesis. And when that heartbeat came on, not only was everyone crying, I was crying. And I realized this is absolutely what I wanted. I mean, just the excitement, the rush that I had, and I wasn't even a part of this. I just was a witness to it. So that's how that's when I knew.
And that's what pulled you. And then, so you knew even before going into OBGYN, you wanted to do reproductive ed.
I knew that I was fascinated. It wasn't, and that was definitely something I wanted to do.
And for the people that don't know, it's a lot of work. Reproductive endocrinology is one of the most competitive fields. There's a lot of research that goes into it. So even if you're fascinated, there has to be something from inside you that's willing to push past those boundaries, do all that extra research to get there. That's why I'm asking the questions, and I want people listening to understand what it means to choose that.
Yeah, it's a great point. It is arguably one of the hardest fellowships to get into. And you can't just say, hey, maybe I want this. You really have to show it through hard work, dedication, years of research, networking, being the best OBGYN resident you can be. And then even though you work 14-hour days, I mean, there were days that I would be post-call on a Friday morning and I would drive to an REI's office and literally fall asleep doing research on the computer because you have to do the research. So yes, you have to be very dedicated and driven to want to do it, and consistently want to do it in order to be successful. And I had a lot of great mentors along the way, honestly. I mean, from both before I started residency to during residency, fellowship that really guided me and helped me along this path. But if you count all the training, I think it's 14 years if you include medical school, residency, and the 2 fellowships. It's a tremendous. So it's a lot. It's a lot of training. But it's for that. You need that training, and being able to apply that to the patient really helps in an evolving field. That's one of the few areas of medicine where things are really changing. We're constantly doing research on trying to improve patient outcomes, and there's a barrier. We've hit 72% essentially live birth rate of an embryo transfer, which is phenomenal. Incredible. You go back 30 years, it was 2 to 3%.
Well, I thought it was about 60, so that's amazing.
Well, and here,
Sure.
well, but here with a euploid embryo, meaning knowing that the embryo is genetically normal, for coming from the lab, because we use CCRM genetics, and it's one of the, I'm extremely confident. I've done my research, I've published research in this field of reproductive genetics, and I'm very confident. I know that when that lab tells me that it is a normal embryo, that it is in fact a normal embryo. There is research out there that shows that the lab in which you even have your biopsy sent to, most patients don't even know what lab it ends up going to, actually there can be up to a 20% difference in live birth rate depending on where it's biopsied.
And is it also true that where you freeze the embryo, they do the unfreezing process, the outcomes are better?
Yeah, so it's arguably where the embryo or the eggs are frozen is actually probably the most important, even more than where it's thawed and transferred. Thawing and transferring is important, but the most important is probably actually where it's done. And that's one of the things that I think is really important for patients to be aware of when especially if you're doing egg freezing. There's a lot of pop-up egg freezing companies, which may seem great. It's another thing, cost is always it's always a concern. It's important to know that you do get what you pay for, right? In life, we know that, but in this field, even more so. Where it's frozen can dictate, you're freezing these eggs because you might want to use them in 10 years. You're not going to know if they're any good in 10 years or how it was frozen and before it's too late. So it's really important to make sure that you choose a good quality place for that.
We have a big practice and we refer to a few different places, and I always tell them a few things. If you're choosing the same way when you choose us, when you're choosing someone else, specifically in reproductive endocrinology, you need to be unbelievably picky on the front end. I say that for a few reasons. Is when you're going to someone, I don't care what you do professionally, what happens. So many of our patients, for my wife example, she's a lawyer, she's amazing. She speaks publicly about this, so I don't mind mentioning it. When your fertility comes into question, even it doesn't matter what else you do, it hits your soul in a way that for many people, even if you didn't think it would help you at all or like affect you in any way, a lot of times it does. And that person taking care of you can be like the devil if it doesn't work out, or the angel who just saved you. And sometimes it's exactly the same. So I tell people, you need to know which lab you're going to, but also what doctor. If you did not get the desired outcome on the first try, do you know that they did everything for you? Did they do everything for you? Do you feel like everything was done on your behalf? Because if not, even if they did, you need to be able, how are you going to do round 2? How are you going to move forward? How are you going to move forward to the rest of your reproductive dreams? And none of this is foolproof. As good as this lab is, you don't have 100% success rate because that's impossible. So they need to know wherever they go, hey, this doctor cares about me and they're doing everything they can.
Right. And I think it's more than that. I see it often when people come for second or third opinions. You want someone that's paying attention to you, customizing the treatment to you as a person, and not just, well, I do 1,000 of these or 2,000 of these a year. So we're just going to start everyone with the same basic protocol. And then if it fails, we'll make it change. Right. So that's one of the things that we need to spend time doing is after we do a full evaluation, maybe we can talk a little about what the evaluation looks like. We sit down, we have what's called a regroup. We sit down and we talk about, okay, these are all of your lab. This is the data point and the results based on you, person in front of me. Here's a custom plan that I would write for you that I think will give you the best outcome possible. Or you should some coffee.
No, I'm just moving that out of the way. So I'm not sure if it's affecting Kim.
All right.
But that's all. So let's talk about that. Let's shift gears to an evaluation. First, do you prefer to do the full evaluation here, or do you prefer that doctors do it beforehand?
So I'm fine either way. Honestly, if an adequate evaluation has been done previously by their OBGYN within the last 6 months, it actually makes the first meeting better because I can already in my initial consultation gives them a pretty good idea of where I think we're going to go. Typically, let's talk about a little bit about what
we do everything custom, but there's usually a few first steps of an evaluation. So what would you recommend either a physician who's referring to you or a patient who was trying to advocate for herself to expect from an original evaluation?
Sure. So if an OBGYN wants to do the evaluation, typically there's 5 components of a fertility workup. Maybe we look at, and I go through this with, I like to teach, so I talk to my patients about this as well. We look at the brain, we look at the ovary, we look at the fallopian tubes, we look at the uterus, and we look at the sperm. Those are the 5 components to any comprehensive fertility workup. The way we look at the brain is we're looking at the brain sends certain signals to the ovary called egg food, the hormones, LH and FSH. And that basically just tells the ovary, hey, make me some eggs. The ovary starts making eggs, it actually sends a signal back to the brain in response called estrogen or estradiol, E2, that says, thank you for all that food, stop sending me food. And that conversation typically goes back and forth until one egg grows. When that egg gets large enough, it gets released through a process of ovulation. Your fallopian tubes, if you Google pictures, they look like they're sitting like this. As you know, when someone operated in the abdomen, they're not. They're all smushed like this. They're smushed, they're in different places, they're behind. And they're not actually attached to the ovary. So what the fallopian tube has to do is it actually, at the time of ovulation, is to be able to move, reach out, grab, and suck that egg as it's being released into the tube. Then when you have intercourse, sperm gets deposited in the vagina, typically about 20 million. Of those 20 million, the vast majority get lost. I always tell patients, if you think men have a poor sense of direction, biologically proven. You look at sperm on the slide, they're just flopping around. They have no idea where they're going.
And they don't ask either.
They don't ask.
They're just over here.
They just yeah. So when 20 million sperms deposit in the vagina, only 200 make it to the tube. So the vast majority get lost along the way. So the sperm has to make its way through the cervix, into the uterus, into the tube, meet the egg at the right time. Because the egg, I always tell patients, the egg's somewhat impatient. It's there for about 24 hours. No sperm's waiting for it. It's out.
Plays too hard to get.
So that's why it's important also to look at the tubes. Not only that they're open, but are they functioning? Do they look like they're working? Sometimes a tube can be open, but stuck in place. And the way we do that is through an HSG or hysterosalpingogram.
I mentioned we send a lot of people to different places, and I realized through my tour that you have your own HSG here. I know it's a little bit of a side note. Every other place that I've seen, they have a radiologist do it, and they're not the best at using a speculum.
That's true, but that also speaks to what I was saying earlier. We chose to put an HSG machine in here. And the reason why is because I want to improve the experience. You think about the way it works. You come, you see the fertility doctor or whoever, and then now they're sending you out to 6 different places. And now you're dealing with scheduling with a whole nother system. Here, I keep it all in-house to be able to improve that patient experience.
So that's good to know. I didn't know you had it. I'm going to start sending it here from
Yeah.
The reason why we're having this conversation is how can we make this better for our patients? Now I know, send them here.
So the brain, we look at the ovary, we look at the tubes, we look at the uterus and the sperm. So the way the brain is literally blood work that's done on day 2 or 3 of the cycle, or 4, if they're under the age of 40. And that's something that can be done by an OBGYN for sure. The only thing that's so important is making sure it's done on day 2, 3. You can, like I said, if they're less than 40, I'm okay with day 4. And they need to get an FSH, an LH, and an estradiol. And if I don't have those 3, I can't make an interpretation of how well the brain and the ovary are communicating.
Just for people listening, why didn't you mention an anti-Mullerian hormone?
Well, I actually am going to mention that because that actually is not the brain. That's the ovary. So I do get an anti-Mullerian hormone. So I use 3 different data points when I'm looking at ovarian reserve. I look at the brain-ovary communication, that's the LH, FSH, and estradiol. I look at the anti-Mullerian hormone, and that comes from all the little eggs waiting to get used in the future from the ovaries. That's a hormone the ovary actually secretes. And then I do an antral follicle count or an ultrasound in the first half of their cycle. And that gives me an idea of how many eggs were to grow if we were to give you medication this cycle. And I take all 3 of those data points together to get your ovarian reserve and all ovarian reserve does is it tells me, do you have a little bit of eggs, medium amount of eggs, or a lot of eggs? Do I need to give you a little bit of medication, a medium amount, or a lot in order to get those eggs to grow?
Just a little side point, since this is probably one of my most common questions. Hey, doc, my AMH is low. I can't get pregnant?
Yes. So I always tell patients that ovarian reserve has nothing to do with your ability to get pregnant naturally. Correct. It only has to do with, like I say, if I'm going to give you medication, how would you respond? And it gives me an idea of how well things are working. But remember, you only need 1 egg each month. Right, so ovarian reserve tells me how many eggs you would get if I were to stimulate the ovaries, and it gives me an idea of what's going on, but it does not predict your ability to get pregnant on your own. It is 100% correct. So that's the brain, that's the ovary. While we're doing the ultrasound of the ovary, we also look at the uterus. I do 3D imaging of the uterus to take a look at whether there can be any odd shapes. There could be fibroids or polyps, things that are sticking into the uterus that could prevent the ability of that embryo to implant. The HSG, which is the tube, so that, like you said, is done here. It's speculum, yes. We put some dye through the cervix, and we take an X-ray of the uterus and the tubes, and we can see, are the tubes open? Are they closed? Are they stuck in place? Because even if it's open, if it's stuck in place, it's not going to be able to grab that egg when the egg is being released. And then finally, the semen analysis. And that's something we do here too. That's we have our own andrology lab, we have our own endocrinology lab and IVF lab, and everything's done here in our 16,500 square foot state-of-the-art. Just
freaking huge. I'm so jealous.
It's huge. It's beautiful. Well, you're welcome to come and stand. Maybe we'll get you an office here. But yeah, so that's the basic evaluation. And the truth is, pretty much all OBGYNs can do that. And even if they don't want to necessarily do the HSG, which they can, you can send it to your local center for it. Even just doing the day 2, 3 labs, get a progesterone as well. So the other thing that you can do for patients is patients who have irregular periods. So that's your general fertility worker.
Yes.
Let's say you have a patient in front of you who has irregular periods. So there's a whole host of different things it could be. One of the more common causes of irregular menses is PCOS. So there are labs that you can send for PCOS to kind of get an idea of what's going on. And one of the things I like to do is if they have longer periods or somewhat predictable-ish periods, you can always get a progesterone level 7 days before they think they're going to get their period. Because that tells me, right, So we call it day 21 only because the average woman's cycle is 28 days. But if your cycle is 35 days, then you actually want it on day 28.
Yeah.
Because you want it the mid-luteal. And what that tells us is, are they ovulating or not? Because if they're not ovulating, we have an answer. We know what's going on, and there's a pretty straightforward treatment for it. But there are PCOS labs as well that is very helpful if it's done prior to sending them to us. That would include testosterone, total and free. I like a sex hormone binding globulin as well. I also find that DHEAS and androstenedione, which are some of the precursors to testosterone, can be helpful. Because again, that helps me. The more information I have at that first visit, the quicker I can get that patient started in terms of their treatment process. That's pretty much, the workup. Now, the other category of patients that I see, because I did my fellowship in recurrent pregnancy loss, I see a lot of those patients as well. If you wanted to do like an antiphospholipid antibody panel or APLS panel ahead of time, by all means. A karyotype, very helpful for both male and female. Also, those are probably the two biggest things that would be helpful ahead of time when they come to see us. The other hormones that we'll look at are two other hormones that the pituitary makes, the TSH and the prolactin. Just because if they're really out of whack, or if they're really high or really low, it's something that we can easily fix to some degree. That's pretty much the fertility workup. And then if the more that they have, the faster I can start using advances.
Okay. I talked to you before because we there's some practices that I know you wish were taken care of better from practitioners. For example, you're telling me you had there's a lot of practitioners that just like to give progesterone to fix their cycles. What are the three things you wish someone in my position as a general OBGYN would know across the board that would help their patients and also get them in the best situation for you when they're referred?
Great question. I honestly think most of the docs that I see patients from do a very good job, both of getting their patients ready, whether it's doing some lab work ahead of time. One, an LH and FSH and estradiol need to be done on day 2 or 3. So if you do them on day 17 of the cycle, I can't interpret it. I can't, just because of the way the brain and the ovary work, I'm not able to give anything useful to the patient. Second thing to know is that you can do these labs on birth control, I should say, because a lot of patients are on birth control. And we just know that they're likely going to be lower. So research shows it's about up to a third of.
So, but still do 2 or 3 if you're...
Yeah, you still couldn't work because they're typically stopping your pill. That's why they got their period. So as long as they're not taking a pill at that exact time, you should be okay. It likely will show everything is about a third lower. So your AMH will be a little bit lower. Your LH and FSH might be a little bit off, but we know we can adjust it by a third.
By the most part, okay. But when they're doing the labs, they're stopping their pack for that month.
No, they don't need to. They can. That's my point. Because they just stop if they're not using continuous OCPs, right? So if they're taking it and then stopping it on day 21, day 2 before, and they're taking the sugar pills, yeah, you can take it on day 2, 3. The other thing that I think, one of the things that I've seen a few times that is important is in patients with PCOS or irregular periods, right? So, and I use this because I love to teach. I have like a whole stack of, I don't know where I show that one. Because I love to teach, I have a stack of like articles and different things that are really helpful for patients to understand what's going on. I always like to go over the menstrual cycle with them and explain like what is happening at the level of the ovary, what's happening at the level of the uterus, and what's happening with all the hormones in the blood. So just briefly, when you have a 28-day cycle, and the reason 28 is just the most common, it's mainly the first half, or the first 14 days.
Anything to about here?
Yeah. The first 14 days is follicular, meaning the ovary is growing a follicle. Around day 14, it gets released. You get your period 14 days after a follicle is released. So if you have a 35-day period, you're still releasing that follicle 14 days before your period. It's just that it takes a lot longer for that follicle or that egg to grow. So it takes 21 days to grow before it's released. That's why you have a 35-day period.
Yeah. So like what you were saying is, hey, the second half of your period, the luteal phase, of your cycle, is always 14 days. The first half can be longer or shorter.
Correct. And that's what dictates how long of a period you have. Now,
So you should wait to have sex when you ovulate, right?
so you should have sex before you.
There we go. That's what he added.
The ideal time to have intercourse is going to be the 1 to 2 days before ovulation, which is when your ovulation predictor kit turns positive. That's another thing that I see is confusing. When your ovulation predictor kit turns positive, you haven't ovulated yet. What it's doing is it's detecting a sudden rise.
So this over here.
It's detecting LH, which is a huge rise in the hormone that the brain is sending. That's what triggers or causes the ovary to release its egg. So when you turn positive, it's typically somewhere between 12 and 36 hours later is when you release that egg.
Got it.
And that is the ideal time statistically to have intercourse. If you wait till after you ovulate, your chances are significantly lower. Now, once the ovary releases that egg, the area where the egg was growing, the follicle, becomes something called the corpus luteum and makes progesterone. What progesterone does, so the ovary now makes progesterone, and what that does is it prepares the lining of the uterus for the embryo to implant.
So does that mean everyone should take progesterone when they're in the second half of their cycle?
No, because your ovary is making progesterone all by itself. There are very rare cases of there's mixed literature on whether there's something called the luteal phase defect. We can kind of put that aside for a second. But no, standard progesterone is not something that is needed.
Okay.
What's important to understand is that it is the ovary makes progesterone for about 9 to 10 days or so. Then, if you're pregnant, pregnancy sends a signal back to the ovary, hey, keep making progesterone. Even if you're not pregnant, the ovary stops making progesterone, and it's that drop in progesterone that causes you to bleed. So when patients are having regular periods and they're put on progesterone, what I've seen many times is people thinking, well, I'm getting regular periods with my progesterone, therefore I should be ovulating. But no, because the progesterone's only working at the level of the uterus, it's not making you ovulate. It's not doing anything to your ovaries. I think there's sometimes a miscommunication. I give patients like that progesterone, but not to get them to ovulate. I give it to them so they don't get cancer. Yes, and that's important, right? You don't want them to have more than really 90 days of unopposed estrogen production exposure. There's no question about that. But I've seen it a few times where people think that they've been treated for their infertility by progesterone because they're having a regular cycle. Or having a regular cycle, but it's not because your ovulation is working, because your uterus is shedding when you give this.
I feel like you're on birth control.
Exactly.
Because you're withdrawal bleeding.
Correct. It's exactly what you're doing. Withdrawal bleeding. So that's a lot of information about just what a workup looks like.
But yeah, it's a good way to explain also what is going on before you even show up. Let's say someone comes into your office. What are the services you offer here? Because another thing I recommend, hey, go see Dr. Bardos. He's a reproductive endocrinologist, and some patients go, I'm not ready for IVF yet. I'm not ready for that. And I tell them, I'm not asking you to do IVF. There's other things that they can do to help get you pregnant, or at least to have a consult so you know your options.
Yeah.
So I try to really push that as there's more things that you do. So you're not an IVF doctor, you're a reproductive endocrinologist. So can you just explain more, as a reproductive endocrinologist, your scope of practice?
Yes, I love that question because I do have patients that sometimes come in, and I always like to start my consult and say, what brings you in here? And the first thing they say is, I'm not doing IVF. I was like, okay, that's fine.
That's how you know it's something.
I'm like, that's fine. That's not my goal. And I tell every patient when they come in, my goal is you to get pregnant. Whatever way we need to, that's my goal. So if you simply walk out of here, and I have patients that just by coming to me and offloading the responsibility, because I tell them, it's now my responsibility to get you pregnant.
The anxiety drops, and then...
And not to say that anxiety is the cause of infertility, but it is a cause. It is a part of the myth.
Yourself, yeah.
And there are patients that just simply get pregnant after seeing consults, which makes... And I tell them at the consult, if that happens, you tell me, because I count that as a win.
Yeah, of course.
Any pregnancy. Now, there are many different reasons why patients struggle to conceive. It can be simply issues where they're not ovulating. And if they're not ovulating, the answer is something called timed intercourse, which is just making them ovulate and telling them to have sex at the time in which they're ovulating. So simply lining up the release of the egg with the sperm. That is probably the most basic that we'll do. It's called a time intercourse cycle. You take a medication by mouth. You see me once or twice during that cycle. Once the ovary is growing an egg that looks like it's mature, we give you a medication to ovulate, so we know when you're ovulating and you have relations with your partner. And that is probably the simple one, and I do a lot of those cycles, just because oftentimes, even in the religious community, there can be situations where a woman's bleeding too long, and therefore she's not able to go to the ritual bath before she ovulates. So there's a simple, I see a lot of those patients, and
we have for people listening, we have a very low rejection of the Jewish population here. So that comes into terms with two things that you said. Number one, you're talking about timed intercourse, but another thing is the increase in genetic conditions.
Yes, so which is another thing that I think is important to do either at my office or before you come in, which is expanded carrier screening. But there's a simple solution. If you're ovulating before going to your ritual bath, I give you 5 days of estrogen the first 5 days of the cycle, and that basically pauses your ovary from growing an egg. And then as soon as we stop it, it starts. So you basically just gained 5 days and just pushed off when you're going to ovulate by 5 days.
You just made a 28-day cycle,
32 days, 33 days cycle.
Oh, there we go. I can't do math then.
But what that does, that often just solves their issue right there. But so knowing why or what some of the issues are that patients are struggling with can really help guide care. It can be as low intervention as just a timed intercourse cycle. It could be we see that there's a mild male factor. Maybe there isn't as much sperm. There's sperm, but it's not as much, and they'll benefit from an IUI or taking the sperm, washing it, and putting, instead of the 20 million going in the vagina, now putting 10 million close to the tubes, really increasing the chance of that egg and sperm meet. Yeah. And sometimes IVF is necessary. I typically don't start with IVF.
Unless they're above 40 and they want a bunch of kids.
Right. So the literature, after we've done a workup, the literature does show something called the 4T trial, basically looked at women if with unexplained infertility. So if we've done a workup and everything looks totally normal, it doesn't mean there's no problem. It means we haven't found an easily identifiable one. And oftentimes IVF is going to be the answer for that. And through the process of IVF, we always talk about, sometimes it's diagnostic too. We learn in that process that, hey, because now we can see your eggs, and the eggs come out, we can actually look at them under the microscope and see they don't look so great, or there's some issues there, or hey, the sperm doesn't penetrate properly. So we learn a lot of things often through the process of IVF that may explain why patients,
which also goes back into the importance of OLA. Another thing that, by the way, because I'm talking to you here, we did not talk about the main cause. Like we usually say a third of the time it's like a female cause, but a third of the time it's the male, and sometimes a third is unknown completely.
Or a combination.
Right, exactly, or a combination. And for people who are having issues getting pregnant, not all partners are as amenable to a workup. I don't know, men sometimes have a little more of an ego as far as their...
I don't know if it's ego, we just hate doctors.
So it's fair. I'm the worst. It's okay.
I'll tell you that.
I mean, yes, that's fair.
But yeah, I think also for whatever reason, women are used to having gone to the OBGYN. Men don't have that process. We don't see a urologist
until you're like 50. Yeah.
Right. Until you actually have a problem. We're problem based. We have a problem, therefore we go.
Yes.
And women are usually more proactive. They're used to they've had OBGYN exams. They're having their pap smears. They're taking better care of themselves.
But I also encourage people when we talk about the original workup is, hey, before we start putting contrast in your tubes and start poking and prodding, get your partner checked.
Yeah, and I think a common misconception from the male side is that since I have ejaculate, I'm therefore fertile. Yeah, and one of the things that's useful to explain to patients is that ejaculate is made of a lot of different things, including sperm, but you could have ejaculate and have zero sperm in there. Or you can have ejaculate and have some sperm, but very low amounts, or sperm that doesn't move. So yes, looking at up to almost 40% of the time, the male can play a role. And sometimes that's all we find. We find a mild male factor. Sometimes we find a severe male factor. And then that helps really dictate care, or guide care, so that we can get the best outcomes for patients. So it is important that the partner gets tested. And from a religious standpoint, that it's important to connect with whoever the person who's guiding you, and that you choose someone that knows this field, right? There's a very intricate special field, and I do specialized training, rabbinical training in this field, so I'm able to talk to a lot of the rabbis and speak the same language, kind of like how two doctors can sit down because we've done that training. We can speak a lot of the same language, a similar concept.
The tougher part for us is to remember that we're trying to talk to everyone and not to each other, and not just geek out on random small.
I mean, we could geek out too. We could do a separate time, but we can geek out.
Well, yeah, that's for a different podcast. But just to kind of recap here, when you go see a consult, we're looking for, obviously, to get pregnant, but that ranges from services from doing nothing and literally, like you said, emotionally offloading, to genetics, to doing a primary workup, to something a little more invasive, like you said, called an IUI, or even before then, cycle timing to get someone just to ovulate, not with progesterone. Yeah, that's for you. And then on the extreme side is IVF or egg freezing, depending on your personal situation. Is that correct?
Yeah, exactly. And sometimes, when I get a number of consults that come from the OBGYN after they've done carriage screening, which is another one of my many side interests, which is reproductive genetics. So carriage screening, I think, is really important. And a misnomer that a lot of patients have is, well, I've done genetic testing before. Now, genetic testing is basically saying, like, I've seen someone in the field of medicine. What does that mean? I mean,
it usually means they did 23.
Well, no, but my point is that there's so many different types of testing that's out there. And even if you've had, most likely it's been a very, very limited subset of disorders. And it's really important to do expanded carriage screening. We used to only do ethnic-based, where we said, oh, you look like or you say that you're, only from Ireland, and therefore we only need to check Irish diseases. But then when I actually did this research, where we saw that when we do an expanded carrier panel, actually, wait, hold on a second, you're carrier for things that are not associated with being Irish or Canadian or South America, wherever you're from. So it is, I strongly encourage all my patients to do it, and to do both the husband and wife.
I think we need to make a whole other episode on just genetics.
Sure.
So I think that'd be great.
Yeah.
But I know you're on an ad crunch, so just to wrap up here, what eminent? I got to also get all the information away from you. So, no, I'll take that. Yeah, that's fair. No problem. They can wait.
It's just the CEO.
3 things you wish a patient knew before coming here, like misconceptions, or things I wish that they would know coming.
I mean, choosing, like you said, choosing the right clinic is so important. I think that if you've tried twice elsewhere, definitely change. Doesn't have to be coming to me, but I would definitely go to a different location and try a different location, different lab, a different setting. So that's one thing that I think is important. 2, your doctors do care about you. I mean, we went into this field because we care. We're not just bad. I don't know what the word would be, but we're here because we care. We want to help you. If you have medical records previously, it's very helpful if you bring them in. And the process takes time. It does. And from the moment you see us until we get to any form of treatment, there's a process, and it's hard and it's frustrating. And I get the fact that every patient that sets foot in my office wanted to be pregnant a year ago.
100%.
And we know that we're going to work with you on that, but it does take some, and it's hard. It's hard for patients. I get it. And I would say crying aloud. I have tissues in my office for a reason. Patients often are like, I'm so sorry, I'm crying. I'm like, no, that's why we're here. You're allowed to cry. Because I do a lot of recurrent pregnancy loss, miscarriage management, and it's very hard for patients.
We should do another one on just.
Yeah, these are all like passions of mine, really. But my passion is getting people pregnant and getting them to live birth, making sure, getting them to the ultimate goal of taking home a baby.
Amazing. Listen, I think this was wonderful. We're going to do this again.
We definitely should do it.
Well, we may just do it online, but there's so much to unpack there, and I think it'll help both our patients.
What else do you think would be helpful for patients to know? What are some of the things that maybe patients ask you before they come to see us?
I think we should definitely talk about recurrent pregnancy loss. So I don't even understand that even if they've had multiple pregnancy losses, if the workup's completely negative, that their chance of pregnancy is still quite high.
It is quite high, actually. We can talk about egg freezing. Yeah, so many different things to talk about.
We'll do. So I don't know the exact.
Oh yeah,
yeah. Actually, I don't know the exact thing here. This is just a graph showing the probability of success after multiple losses.
Right.
So I also like to teach, and I show them the same silly figures, which I feel like
We should go over all the figures. But so recurrent pregnancy loss is one of those areas where I tell patients doing the same thing, you think that doing the same thing over and over again and expecting different outcome is a definition of insanity. It's not in this field.
correct. On that note, thank you guys for tuning in. Definitely,
Yeah, no, this is fun. I think there's so much more we can talk about. So
we definitely will. Alrighty, have a good one.